Thank you very much for three great presentations, I thought, and really good food for thought. And I was struck right at the beginning in Jesse's presentation of when you use the word purposeful, because an old leader that I worked with said, serendipity is not a strategy. And I think sometimes we expect things, we'll set them up, and by serendipity, various things will occur. And I think you saw some good examples of some purposeful developments. And we structured to kind of to try and provide an overview, but as well as some practical examples. But it's open for questions, and I think there's a couple of mics here I'll pass to people that they can use just to turn on. I'll use that and here. And I will run around, so hopefully there is some questions that people might have, or I'll be in a position to have to fill that to start off. Okay, I'm going to start off, I guess. In terms of Jesse, not putting you on the spot, but I think the incorporation of integration, what might be the next steps in defining what might be some metrics that might be used in various areas by HQA to be able to regularly report to Alberta around the quality dimensions that have been identified? If you can answer that question.
Testing. Is it working?
Yeah.
You know, John, that's like the most common question I'm getting. And so I've had the opportunity, I guess, to think about a good response to that. And actually, I'm really curious what Jodim and Ray would have to say after listening to their words. I'm not sure it's up to Health Quality Alberta to determine the KPIs independent of others. And so people are asking, Jesse, what are the metrics going to be? And sure, we can scan the literature to see what other jurisdictions like New South Wales have done. And I do think at a macro level, there's some good common ones. But I think we all need to come together collectively to discuss what we want those performance metrics to be, depending upon whatever dimension it is that we're talking about, to make sure that there's alignment between the priorities that are existing at the government and agency level, but also based upon the context that we are currently sitting in Alberta. So what do we need to be monitoring against based upon the goals and objectives and what matters to people and communities? And so I think an interesting conversation to be had is, how do we get those macro level measures in a way that reflect also what matters to people and communities? And I haven't quite figured that out, but I think it is about convening in conversation and making sure that there's alignment between all of those competing interests.
Okay. No, thanks. And Jodim, and this is my bugbear because of why I asked the question in terms of what are some of the measures that you might do top down as enablers. And Jodim, I don't know if you have any comments about the usefulness of high-level, system-level metrics in driving integration. Any thoughts or some examples of jurisdictions where you think this has been done sensibly and well?
I really appreciate the question because we know no matter our metrics, the way in which people are engaged around those metrics matter so much. And so identifying them at a health system is critically important. And it is true that there are common metrics that we see time and time again at a health system level. What we don't see are the metrics that align to what are most important to people and their families. They're in some places, but we don't see them at scale. When we start to see them at scale, Scotland's an example, but there are other examples like the Nuka health system, we start to see some of the best health outcomes. What's interesting about that is then who's involved in helping achieve those metrics fundamentally changes. So for instance, we're not only considering those that are publicly funded by our health system. Cecilia's in the room, the CEO of the Alberta Chiropractic Association, as an example. We have strengths in our provinces and our countries that help enable health and well-being, help people and their families achieve what's most important to them. And so the secondary piece is, what are those resources that are available to us We can work together to achieve what's most important to people in their families that are actually set out as our system goals, on top of the ones that are commonly held and used.
Yeah. And Ray, you briefly went through it, but you were having to kind of get to your, because of my prompting, to your presentation quickly. So I don't know if you have other comments in terms of the usefulness or steers from your experience of some top-down indicators, things that you felt could have accelerated reform or things that should have been done differently in that.
I don't know if it's...
No.
It's on. It's on.
Oh, try again.
Can you hear me?
Yeah.
Okay. I don't know if it's contentious, but I'm going to say I don't know if the measures actually matter. Because I've seen it happen in a lot of health systems where they're very similar. So they always have the domains. So again, the domains, being a data person, it's hard to say this, but the domains are important. It's important that they're balanced. But if I take ER performance as an example, in New South Wales, the Premier said 81% of people are getting through the ED within 4 hours. That's going to happen. They had a Premier's implementation unit that were all over the health system doing surprise visits and trying to work on the problem. And we were saying, man, we have to make an improvement. And so we were looking at outlier hospitals. And everyone got super focused on, well, when do you start the clock? Where do you end the clock? And which data field is that? And all of a sudden, performance improved because, right? So that got us half the way there, was quality of data. Everyone's looking at the same information. And then it became about real improvement, not just data improvement. And what did we find? Well, lo and behold, as Jodim says, the people that are taking the longest in ED are socially isolated, homeless, frequent flyers. This is a integrated care problem. This is a community problem. This is a, how do we connect them with social care and education? And that's when the system began to bring other partners into the room. So even though the measure was ER, wait times, it's not about the ER at the end of the day. It's about community connection and integration. So again, I would just encourage the system, I guess, whatever system I'm in, to start. And then every year, adapt as you go. Because the conversation about the measure and the improvement is what's important.
Yeah. And just previous forum we had here once was performance measures being seen as useful to the community, I think is important in that accountability, because I know the UK did some very tough, and I think they called it targets and terror, and I think in New Zealand it was rank and spank, and so it became some short-term improvements, but it was not sustainable because it really wasn't well regarded by the culture. But we have first Jody and then Dawn.
Okay, so Ray, following up on that, I've had this experience so many times. I think folks salivate at the idea of getting to a place where you've got tiered, relatively accurate, close to real-time reporting of health system performance across all these dimensions. Sometimes it is hard to sustain the commitment to the actual effort, investment, coordination that's required to get there. And I'm curious if you have any tidbits about what it took to sustain the gap between, oh yes, I want that, and the actual effort required to get there.
I think it's a great question. It sounds cliche, but quick wins. So districts, local health districts, hospitals would get called by local MPs, government, like, how are you going on this? How are you going on that? And so we could solve a problem immediately to say, there are only 31 problems, 31 KPIs. These are the ones that matter, and point everything towards this framework and this process, and kind of funnel that through ministry and through these meetings. So it didn't solve, obviously that's still going to happen. They're still going to get political pressure. But we were able to show, and especially the one that was picked out by government, whether it's elective surgeries, all done within clinically recommended times, always contentious, that really made a difference. And I would say also the connection between those assistant coaches, so purchasing being linked to performance, because every time we would go meet with local health districts, they would say, yeah, but you don't give me enough money. And then the conversation became, okay, well, what would you do with more money? Show us the money you're using. But it's collective, it's collaborative. It's not like trying to call each other out. It's just we're trying to solve the same problem.
Perhaps just a quick build
Okay.
on that. We know when we're doing this work that we are holding so many multiple tensions. The multiple tension of how do we sustain the multiple tension of we're restructuring well, we're improving, the multiple tension. There's multiple tensions. And our job, I believe, is to understand how to hold and love those tensions and find a path to create the culture and the conditions that allow us to thrive. And it's hard especially when we look at data in a learning health system and the commitment, we hold the tension of short-term wins with long-term gains and aspirations around health and well-being. And I know this seems maybe, it's a big provocation, but here it goes. Where are we holding the spaces so that we can actually create new containers together to say, across our various hats, we have these incredible levers. What are the new containers that are going to help us get early wins, but change the culture in which change happens, and help us work together in the long term? In the short term, demonstrate value and impact, and set the conditions for the long term. And I often find, wherever I am, and this is an opportunity sitting in front of us, is who's creating the new containers. Very often we're going back to our common containers to make the kind of change that requires a new container for radical collaboration and changing the culture and the skills and the way we connect to be able to honor the 31 KPIs, not just in a local community, but across a country.
Okay, thanks very much. Don?
Thank you very much for 3 great presentations. As an old leader in many parts of the system, it's always inspiring to hear this. And as a person who's still involved in our fellowship in health system improvement, I'm glad to see some of our graduates in this room. What I think about is there really a silver bullet? Ray says we don't have the silver bullet. But when I reflect on your presentations, Jodine says every person, every day. Ray talked about passion at the front line. And when I listen to these presentations, one of the things I always think about is, how would this relate to the person on the front line today?
Yeah.
And how would it relate to the citizen who's going in there?
Yeah.
Everybody who goes to the health system is on a health journey of some sort or other. And on that journey, each practitioner has a hand in helping with the transitions, the handovers, and so forth. And I don't think in all the work we've done and work I've done, we've created health regions thinking that was the answer. Mm-hmm. We never get down to how do you inspire that person on the front line as they see that patient in front of them or the citizen coming in to think about not helping with their immediate problem only, but how do you create a journey for them through the system, an integrated journey. And that's the part I feel is really missing. Mm-hmm. And I think that a lot of people in our system right now at the front line are quite demoralized. They feel overworked. We've got no time to do all this. Mm-hmm. And yet they're critical. This is not going to happen without them. So I'd like to hear from each of you any innovative ideas. And I welcome in this, because I teach the international part of our program, hearing from other countries. How do we get to the front line at a time when they feel overloaded, overburdened? But they are part of this. They are the silver bullet to this. Yeah. And that's, how do we get there?
Who do you want to start? May I start? Okay.
Go ahead.
So if I could wave a magic wand, it would be, how do we create the conditions so people thrive? And there's often a gap between what we say we want to do and the conditions in which we're doing it. And there are communities in different parts of the world that have said the culture for change and creating the enabling conditions is what is going to allow us to achieve these higher level goals. And what that looks like is very different than what exists. So examples that are very practical. Training to support clinicians no longer happens within an organization, ever. It happens across organizations. Home care, primary care, specialists, people in their families, rehab specialists. I'm just giving examples. We actually learn together. We unlearn together, we grow, and we have impact together. This whole idea that the way we are trained and supported in our frontline roles, I think we have an opportunity to fundamentally change. If you look at the integrated care systems in the UK, there's 3 of them that are achieving population level goals. And if you look at the quintuple aim, including staff satisfaction, it's going through the roof. Why? Because they've created like a chief transformation office. Like, imagine if we had a chief transformation office in our country, in our provinces, that then translates into our communities. They're helping support, create the conditions to work this through, to understand we're connected to something bigger, a higher aspiration, to build the skills, to actually, you know, if I usually hold sessions with hundreds of organizations at a time, and they bring their teams, and I ask them, how many of you know each other? I don't know, like 2% of the room's arms go up. And how many people do you think you're serving in common? 100% of the room goes up. And so your question for me is the most important opportunity sitting in front of us. How do we create the enabling conditions so that we fundamentally shift that?
Okay, Ray?
So I'm going to give you 2 ideas. One is individual ambition, and the other is collective action. So everything every one of the people that you mentioned is doing is important. And so our job as leaders is to make sure they know that. They already know that, but like support them in any way that we can. Collective action is not about, well, it is about the whole Alberta system, but it's also about the practice in which they operate. The population can be thought of as the practice population, the number that are attached to that practice, or the hospital patients that they're serving at the regional level. So I always think, like, what's the opportunity in front of me today to work with other people, whether it's just within my service or across a number of services, or the region or the province. Sometimes at the province doesn't exist because there's restructures happening, but that will exist again. So what can I do at the regional level? What can I do in my own practice? So it's within the control, it's within everyone's control to do something today. And it's all about timing for me. But it oscillates between, like, what am I doing individually, and then what are we doing together?
Yeah, and just from some past discussions, I do think, Don, there are sometimes interprofessional, team-based barriers, because I know a lot of doctors and nursing people said, hey, we could solve some of this ourselves, but there's also payment systems in which people are clearly not paid to take time to do that, or not resourced with the additional staff. And so I think the primary care medical home, I think, which might be really advanced, sets up structures to allow staffed people paid in a way to allow to do some of the integrated and person-focused services, where sometimes there's a barrier to doing that, except out of the goodness of your heart.
That's exactly what we did. So
yeah.
When I talk about the 5-10% missing, we actually grant funded physicians and nurses and even receptionists, like time to integrate their model and do quality improvement.
Yeah, and so I think those, particularly for those specific populations, perhaps first, that might require and take more time. Rebecca, you had a question.
Oh, thank you so much. I love that so many of the themes that you've touched on, such as data, performance measurement, complex adaptive systems, one of my favorite things, all kind of come together and are related with this integration. And I'm wondering if you know of any good examples or approaches around taking that complex system approach to the measurement. So it's not just these individual KPIs and these simple ones, and what are the balancing ones? What are the ones where if you improve wait times, that all of a sudden you're having a negative impact over on beds and capacity somewhere else? And is there a way within this management of these performance indicators that isn't too complicated, but that also takes that into account as well? That interconnection between the things that we measure as well.
That might be for me.
Sure.
I'll go first. I don't know if it's probably been done, because I feel like everything's been done, but we weren't that explicit in terms of, like, if you improve flow through the ER, you increase the number of beds, and then you've got a discharge. Like, we all know that to be true. And part of improving ER performance rolls into the wards and out to discharges. And then there's, block on the back end trying to get into long-term care and continuing care, and all that becomes part of the problem, which is why I think it's so amazing to have one or two kind of things that focus the system, because it leads to a whole bunch of other things, and it gives you an opportunity to raise it with government, saying, actually, if you want us to improve flow through the ED, we actually need more continuing care beds. And they're like, what are you talking about? It's like, well, here's the flow, here how it works. So I don't think it's as explicit. What I've found to work, I guess, is 1, 2, 3 kind of really priority things to like galvanize effort across the whole system. So not to say everything else isn't important. It's a complex system. It's a wicked problem to solve. But having the system focus on a few things is actually quite meaningful, especially if government has given those things to the system, because then the issues that are not solvable on the front line can be solved because everyone's wanting to solve them.
Okay, and we just have two quick questions and quick answers, because then we're going to have to kind of close, but just quickly.
Hi, I have a thought on looking back.
Is it on? Yeah. Oh, sorry.
Looking back at the health system, I think we have been pretty good at defining indicators, KPIs, measuring it, putting the data infrastructure, capture the data, and reporting like monthly report, quarterly report, etc. My thought is that we are very good at this. What I think there needs to be improvement is, so the conventional wisdom is we give data to people, they will reflect on it, and they will improve. My observations tell me that people, you give them data, they don't know. Sometimes they don't know how to make the improvement. So what are your thoughts on this?
So I'm of the view, after 25 years, that writing a report and sending a performance data doesn't actually change anything. It's the conversation that changes, and it becomes like, who is asking the question and what question are they asking? So in the context of the example I gave in New South Wales, it's the ADM wants you to explain why 100 patients were in ED for 12 plus hours. Can you please explain that at the next quarterly meeting? And a month later, it's amazing the solutions that come. Both the ministry has to do this, and we need help with this homeless issue, and then that's a problem to solve together. So I think it's, I guess, I don't know if I'm answering your question, but I guess I'm coming back to having the data is absolutely essential, but asking the question and having the conversation to follow is what's actually going to drive it forward.
And Jodim, I think you had mentioned before the importance of the people have to learn how to work
you have
into
to
the
create the
system.
conditions to even understand how to use the data, the learning health system approach, which comes back to culture. And it comes back to setting the conditions so that we're learning forward, and the data is a lever, not a report that we have to sense make and not know yet what to do with. And I think there's good, you asked for examples of where this is happening. So the Birdsong model, I think, might be very familiar to people. Birdsong is in the UK, but they're part of an integrated care system. And the integrated care system has the KPIs or performance measures. What I love about Birdsong, it's the adaptive, it's the conditions outside of the hospitals that are helping support non-readmissions and admits. It's because it's a complex adaptive system, and they're looking at the secondary measures. So there's an example, but then it's the same example of a learning health system approach, because the data is helping inform how we move forward next.
Yeah.
But can I just, sorry, John, just to add, just coming back to the coach and the assistant coach example I gave. Mm-hmm. So everyone is actually around the same table.
Yeah.
So purchasing, black hat, performance management, white hat, quality improvement, data. So someone obviously says the data's wrong. Let's have that conversation in the meeting, take it offline. There's legislative frameworks not allowing me to improve this. The budget's not sufficient. But that's the conversation, because we're all trying to solve the same problem. So that's where the value's at.
In Canada, we have the Impact Health Fellows. So they're embedded at the point of care in teams. And they're like our alive data, sense-making, help us, make real-time improvement in real time. Back to what amazing assets we have in our country.
Yeah. Okay, last question.
Okay.
Thank you. Hi, everyone. It's wonderful to be here with you, and thank you for 3 great presentations. I want to make a book recommendation based on the discussion over the last few minutes. Humanocracy by Gary Hamel talks about how businesses and organizations should be focused on people.
Yeah, humanocracy.
Humanocracy. Thank you.
Yeah.
Secondly, today is World Patient Safety Day. WHO and countries around the world are celebrating safe care for every child and newborn. So happy Canadian World Patient Safety Day to all of you. Each of you mentioned safety, which makes my heart filled with joy. And in closing, I wonder, what's your aspiration based on what you know now and where we should go in terms of patient safety?
To be on the spot.
Well, actually, I think reflecting on enabling conditions, I think leaders in health systems need safety to have uncomfortable conversations and to show up and be vulnerable with one another. And if we are able to do that and find ways to have difficult conversations, we're going to have that downstream impact on improving patient safety on the front line. So if I was to wave a magic wand, I would wish that we all could be comfortable and feel safe having important policy conversations, for example.
Great question. Love safety. I don't know if you saw on the screen when I flashed up the performance framework, I flashed up the patient safety and quality framework. So 5 years after we did the performance framework, we did safety and quality framework, and LHDs, local health districts, had to report to the public. It's called a safety and quality account, what they're doing to improve safety. And it's all about people, as you said, because what we know is that you cannot take a compliance performance approach to safety because then people don't report incidents. So the safest hospital is not necessarily, in the data, is not necessarily the safest hospital. So it's about monitoring, root cause analysis, people feeling comfortable sharing. It's creating the culture, the conditions to improve safety. It's a whole nother presentation, I think, in discussion, but great question.
The book on humanocracy is such a wonderful example of our opportunity to consider the possible future of patient safety in our country, which is about person safety and person health and well-being. And when we start to understand that that's our possible future, then the way we think about quality frameworks, the way we think about our approaches, our policy levers, our data levers, our leadership levers, our frontline levers, and people with lived experience and their families, we start to understand that if we start to line them up, we have this ability for impact that will enable the health and well-being that humanocracy talks about.
Yeah, and just to give a plug to Alberta-related things, again, in terms of integration or interoperability of data. Alberta's done some work around with Dr. Ewan Affleck and others, and it's moved into the OECD and CIHI and participating in trying to define interoperability or lack of integration of data as a safety issue, as a potential harm for the system. And providers respond to harm and safety messages much more than you're wasting money or you're that kind of thing. But people in the system, frontline, as Dawn mentioned, respond to, they don't want to cause harm for the particular patients. And so presenting interoperability and the lack of integration as harming the people, I think is a potential good driving force. But thanks very much. Great that we had the common sharing, which everybody should share, about the new definition of integration and the quality framework that we want to all live by. Cut it out and put it on your desk, kind of thing, and share it around. Great to have the international lessons, which we will share in those connections, join up and become part of that particular vibrant community. And this all has to practically move into purposeful implementation, and thank you, Ray, for sharing. This will all be posted, including the presentations plus the video, and share it with your colleagues. But please join me one last time and thank our great panel.
Thank you.